So hi everyone, my name is Mohamed. I'm sure you've all met me before doing the IMG Forum. I'm working as an education fellow and plastic surgery registrar. And today we'll just talk about how to do an audit. Because it's very easy. And the whole purpose of this is to actually get you guys to think about audit ideas now and think how you're going to do your own project. And I'll show you how easy it is to actually get started. So what we'll talk about is briefly just what an audit is, in case anybody's not aware of what an audit is. It's a very common interview question as well, so it'd be good to keep it in your mind. And what the difference is between an audit, research, QIP, clinical governance, all these things, just to avoid any confusion, and why we need an audit. Why is it important? We'll talk about how to get it started, because that's the most common question, and all the steps you need to take. And I'll show you an example of an audit. Then I'll get you guys to try to actually think about an audit and how you're going to do it, like brainstorming ideas. So let's start. Does anyone know what an audit is? It's very simple. An audit is, there's a lot of definitions or fancy terms, but I think easily the most simple form of it is it's a way to measure our practice against standards. So are we, in our practice, are we doing things right or not? Are we actually following the guidelines or not? That's it. So it's a practice-driven process, and that's the whole point of an audit. So it's different from a research because the research is aiming at producing new standards. It's aiming at answering questions that have not been answered before. An audit is just seeing whether we are actually applying what we know in our practice. So research is theory-driven and audit is a practice-driven process. A QIP is very, very similar to an audit, but the main difference is that a QIP is not governed by a standard, it doesn't have a standard to follow, and it aims mostly at improving practice. So it's a quality improvement project. It doesn't have a standard, and that's why it's different, but it's a very similar process to an audit. But if you don't have a standard, then technically what you're doing is a QIP, not an audit. If you have a standard you're following or measuring against, then it becomes an audit. And the clinical governance is the umbrella term that covers everything. This includes teaching, research, patient safety, and audits as well. So it's like an umbrella term for all the things we do to help with clinical governance. It's like an encompassing term. So common question, why should I bother? Why should I do an audit? And I'm sure the most common answer is because you need it for your portfolio and your training applications, which is, yeah, it's true. That's the most sought after thing in your wherever you're applying for first grade jobs, for training jobs, for interviews. They always ask about audits and clinical governance. That's why most people do it. But if you think about it, the reason they actually value it in portfolios is because it helps improve practice. Because it's designed to make sure that what we're doing is actually following standards. So if we're doing an audit, this should be your ultimate goal, to actually improve what you're doing. And as a secondary goal, you can get a point for your portfolio, of course. So it's like a short-term and a long-term goal. The first thing you ask is, how do I actually start it? A lot of people are just don't know where to start from and get confused. They don't know, where do I begin? How do I find an idea? How do I find something that works? And you end up looking for people to guide you or asking someone to tell you what to do. But you can actually do it on your own. It's a very, very simple process. And if you do it on your own, then you're the lead of this project. So it's more points. And we'll go through how to do it. So it's not a very complex process. But if you need more team members, you can always recruit more people to help you. But you don't need to find someone to give you an audit. You can start one your own. And there's something called an audit cycle, which makes this process very simple. Let's start by an idea, top right. So an audit idea or a question, you choose a standard and you measure against it. A lot of people start with the idea, but I find it much easier to actually start with a standard. For example, if you look at the, for example, NICE guidelines, you'll find a lot of standards, things that you can actually measure against, and you just pick one that actually works for you or you think might be useful. So if you start with a standard, then you already have an idea. You can find maybe a recently published article that's very interesting, or find some guidelines which have been recently published by, for example, Royal College, for example, or anything. So you can find standards very easily, and you can start an audit based on that. And then you measure your practice against the standard. Are we actually following it or not? For example, I'll give you an example to make things easier. Let's say there's a nice guideline that on any patient who's on morphine should be given laxatives as well. Very simple guidance. So that's our standard, and that everyone who's prescribed morphine should have an additional prescription for laxatives, for example. So to measure that, very easy, you go to the drug charts, see all the patients who had morphine prescribed, and check if they also been prescribed laxatives at the same time or not, to avoid any constipation. So that's the first step, so you measure it. And let's say you found that only 50% of drug charts had a laxative prescribed. The other 50% did not have anything and just had morphine. So you want to change that, you want to adjust the practice. So you do an intervention. So the intervention is, let's say you do a teaching session for your other foundation doctors to actually know that they should prescribe laxatives. Or you tell the nurses that if they find a morphine only on the drug chart, then they can ask the doctor to also prescribe a laxatives, and so on. So you can do interventions, you can make posters and hang them, or put a reminder on drug charts, whatever you want. Just something that would change your practice in your question. And then you close the loop by measuring it again. You look at drug charts again and see if you've improved the practice or not. Let's say you found 70%. Then you have improved the practice and you've done a full cycle audit, a full loop audit. This is a very basic example, and that's actually something you can do in like 2 weeks. It's very, very basic, and it's a full audit. So it's very easy to do something like that. Now, the tricky part is actually finding an idea that works. You don't have to be very ambitious, and like, let's say you want to change the surgical procedures done for a certain pathology, for example. That's very high end, very demanding, and very time consuming. So you want something that's feasible and achievable, something that you can do, and that's something that's actually realistic in your work. The other thing is that you want it to be useful. You don't want to look at, for example, only 99-year-old patients who have myasthenia gravis, for example, and you want to know whether they're getting the right treatment or not. It's not very relevant. It's not going to help a lot of people, and it's not something that we see commonly. So try to make it something useful that's actually going to make a difference in what we do on a regular basis. And think about your intervention. Is it something that you can actually change or not? Is it something that's doable or not? Is it, when you measure the change, is it going to improve, or is it something that's so fixed that you can't really change it? And if that's the case, then you shouldn't start to begin with. Keep it in mind. And the other thing to think about is, can it be re-audited or not? For example, if you looked at the past 5 years for rare cases, you might find it difficult to re-audit that after you put your change, because you have to wait 5 years in the future to re-audit. So that's not something that's feasible. So think about the time frames as well, and whether it's something that you can measure again or not. And as a bonus point, think about whether it's something that you can present or not. Is it going to be something that's not been done before? You can put it in a conference. So the good thing about audits is that you can actually present them as a poster, as an oral presentation, and get points for that. And you can also, sometimes, if it's a very good quality audit, you can even publish them. So it's a very, very useful thing to learn about. And always keep it interesting to you. Make it something that's actually interesting to keep yourself going. If you're doing something that's completely detached from your practice, you might find it difficult to carry on. So can you guys think of any ideas now? Any audit ideas that you might find useful? Any guidelines or anything that you read recently that might be useful? Just open your mic and speak. You don't have to raise your hand or anything.
What about testing the idea of preoperative antibiotics to see if they're administered based on the standard time compared to how practice is in elective surgery?
That's a very good one. Exactly. So you can measure and see if there's a guidance. I'm sure there will be guidance by the World College of Surgeons or anesthetist that says about the guidance for these medications, let's say for diabetes, for example, or steroids, additional steroids, or and so on, and stopping some medication. So you can measure that. That's a very good idea. Any other ideas? Got one which is in plastics. Maybe it's not very relevant, but we have a guidance by the British Association of Dermatologists that any patient with an ulcerated skin cancer should also be given a flucloxacillin or antibiotic before the procedure. So that's a very straightforward idea people can do. It's related to plastics, for example, but that's one idea. Looking at the NICE guidelines, there's guidance for asthma, for example. So you can look up and see whether patients are actually taking the right medications or hypertension medications, whether the people are following the guidelines or not, and so on. So you can audit something like that. Any other ideas from anyone? It doesn't have to be complex, just something that might be doable.
What about completing drug charts when the time when you admit or clerk the patient?
Yeah, exactly. So that's a very good audit because if you think about it, there's probably guidance or standard you can measure against. If you can't find one, then it becomes a quality improvement project, which is essentially the same thing. But yeah, that's a very good idea as well. So there's a lot of ideas, and you don't have to find someone to tell you what to do. You can just brainstorm wherever you read something recently or you find something that's not being done correctly, then you can just start an audit based on that. And if you think about the criteria we thought about and whether the idea is suitable or not, then you can actually make something that works. The next thing I wanted to talk about is actually how to measure it, because that's the bulk of the work. How do I measure this practice and whether it's actually meeting the criteria or not? So to measure it, what you want to do is collect information what we're currently doing. Going back to the same example about the laxatives, we look at the drug charts in the past 2 weeks, for example. So we can look at something that we actually have been doing before the intervention. And you analyze this information. I'll show you how to analyze and how to use Excel, but Excel is very, very useful for that because you can use formula and stuff like that to actually get an accurate analysis. And then you compare against the standard. Look at the NICE guidelines and seeing are we doing it or not. Should we aim for 100%? Should we aim for 70%? Should we aim for 2%? Whatever. It will vary based on your idea, of course. But for example, for the laxative thing, I think we should aim for 100%, for example. And then you put your intervention, like we said, and measure again after a period of time. Let's say you wait 2 weeks, and then you measure again and seeing if people are actually doing this or not. So that's an easy way to measure it. So I'll give you an example now. This is another audit I did when I was working in A&E about 2 years ago now in Oxford. So the idea of this audit is that there's a NICE guidance that patients with, I think it's here, patients with suspicion of acute coronary syndrome or ACS, for example, angina or skin cartilage disease, they should receive an ECG within 10 minutes from arrival to the emergency department. And this has actually been shown to improve mortality of these patients. So that was the standard we measured against. And to do that, getting to the actually how we measured that, we looked at, I think we have here about 500, 600 patients. It's a large scale audit. You don't have to do all that. It depends on the scale of the audit you want to do. But we looked at 600 patients who presented with chest pain. Everyone can see the Excel, right? Hope so.
Yes.
Great. So we measured that, and there's no patient information here. And we looked at the time they arrived in A&E. This is usually on the system, so it's very easy to find. We looked at the time where the ECG was done, and we measured the time between these very easily. So 11 minutes, 17 minutes, 16, 5 minutes, and so on. And we just measured how many of these patients, of the 600, actually met the target of getting the ECG in 10 minutes. And that's it. That's the audit. Because it's 600 patients, we can't really count all of that. So we used formula. And this is what I wanted to show you guys. So Excel has formula to actually calculate for you. And it's very easy. The most commonly used one, the one I use the most, is called COUNTIF. If you type equal COUNTIF, this will give you a formula. And this formula counts all the cells in the specific range with the criteria you want. So let's say the range I want is this column, which is the ECG time. So F to F means that all the cells in the column F. You put a comma and you write the criteria you want. So I want any patient who has this value is less than 10 minutes, for example. And you close the bracket, and if you type enter, it will count. So that's the count, which is 151 of these cells had the time which is less than 10 minutes. And if you do it as a percentage from the total, you get a percentage which is 25%. And that's your analysis done. So it's very, very straightforward to use and very easy to do. And you just repeat that and see the trend. For example, this was the first cycle, it was 18. Second cycle, we found it was 20. And the third cycle, which is the one that we just looked at, is 25.6%. So you're following the trend and seeing how you actually improved. And for this audit, we did an intervention, which is very straightforward. We had a team awareness campaigns, like sessions for 5 minutes, going to the handover and just reminding people to do the ECG in 10 minutes, telling the nurses to do it in 10 minutes whenever the patients arrive. And we made a poster and we just hung it somewhere. And that's how we intervened. It's very straightforward, and we remeasured it. And I actually presented this at the conference. It's if you do it right, it's very easy to get all the points you need from a very straightforward process. Okay. We have a lot of people here, so I want you guys to think of an idea. So let's say one of you comes up with an idea, and we'll think about how feasible it is, how manageable it is, and tell me how you would measure that, and then how you would intervene. And overall, we can think about whether it's a good idea or a bad idea. So any suggestions for an idea? Let's use your example, for the preoperative drugs, for example, for preoperative medications. Do you think it's a good idea or not?
I think we need to, we need to see if there are any wound infections related to surgical site to see if it is a good idea. I mean, it's.
I'm sorry, what do you mean?
So like if they don't, so we record it based on the standards, see if the trust or the system is, or the standard is following the protocol.
Yeah.
But then we'd have to run it against the surgical site infections just to see the consequences of not following the standard.
Okay, so this is where it gets a bit confusing. So the audit is designed to see whether we're doing the practice according to the guidance or not. So if you start thinking about whether doing the intervention actually makes a difference or not, then you're actually starting to do a research. You're thinking about answering a question, which is, does giving the antibiotic help or not? Usually your standard will be that there is a research and proven evidence that giving this antibiotic before the surgery actually improves it. So that's your standard. And what you want to do is to measure whether we are giving it or not, whether we are following the guidance or not. It shouldn't matter whether it makes a difference or not, because that's already proven. If you want to do both at the same time, then you're doing a research and an audit at the same time, that this will get more complex. So if you have an idea like that, I think what you need to measure is, are people actually being given this antibiotic or not? So you look at the drug chart for patients who had surgery in the past, let's say 4 weeks, and you just look at whether they had this antibiotic or not. And if they haven't had it, did they have an infection or not? And they should have had it if that's a case. So that's how you measure it. You don't think about whether you're going to make a difference or not, because that's something that's already proven, essentially.
Okay,
Makes
okay,
sense?
now I get it. Yeah,
Makes
thank
sense?
you.
Okay. So that's the whole purpose of being a practice-driven as opposed to theory-driven. So if you can think about it this way, it gets much easier and much simpler, and you actually meet the criteria of an audit. Okay, what about the 5 steps? How do you think it's feasible that you can measure something like that?
On drug charts evolve, so yes, but we'll need to find the patients
Yeah,
that had elective surgery on 4 weeks, which is possible.
exactly. So you can look at on Spear, for example, and find patients who had elective surgery and make a list of these patients, and then look up their evolve notes and find the drug charts, for example, and just look up the antibiotics, see how many of them actually got the antibiotics or not. So that's something that's very feasible and can be done. And how would you intervene? How would you actually make a change? Let's say you found only 50% had the antibiotic, and everyone should have had it though.
Give a talk or put a poster up.
Yeah, you can do that. Or who's your target? Is it the surgeons? Is it the anesthetists? Is it the nurses? Who's going to give the antibiotic?
The surgeons.
Probably, yeah. So you can target this specific group and just maybe send an email to the SDU lead, say you're going to join the academic half day, for example, and present your audit and recommend to them to give antibiotics before surgery. That's it. And that's a lot of people do that. So you see an academic half day, a lot of people present their audits. That's the whole point of doing that. It's awareness. So that's one way to do it. Or you can put a poster in the preoperative assistant area to remind people to do that. Yeah, that's very feasible. So overall, what do you guys think? Is this a good idea or a bad idea? Is it something that's feasible, doable, and achievable and useful? I think so. Personally, I think it's a very good idea. So that's a very good project to start if you want. Well done. Any other ideas? Anyone?
Does it have to be related to the rota we are doing, the rotation we are having at the moment?
No. No, you can collaborate. You can work on something that's in a different department, so long as you can access the data or the information, and you can just find someone who's in the department to help you if you want, just to get more reach. But you don't have to do it in your own specialty. I did one in A&E when I was there, and I also did something on plastic surgery when I was working in A&E. So you don't have to do something that's only for you.
Right, thank you.
Sorry.
I still don't grasp the difference between an audit and a QI project. I mean, they're very similar, I feel.
Yeah, they are. Yes, so it's a bit confusing, but let's say for your example, there is no guidance, there's no standard that patients who had an infection should be given antibiotics, for example. You didn't find any standard anywhere. There's no guidance on the World College of Surgeons, or there's poor quality evidence. In this case, it becomes a quality improvement project because you're doing something to improve the quality of care. And That's why you're doing it, but you don't have a standard to measure against. You don't have a goal or target that you're comparing to, but you're aiming at improving your practice essentially to become the quality improvement project. That's a key
Okay, now I
difference.
get. Thanks.
Any other ideas, guys? Anything you've been thinking about? We can always think about it together and see if it's working and get some ideas.
How long?
I have a. Oh, sorry, Henri. You go, Henri. I talked a lot this day.
How long does it take on average to conduct an audit? I mean, I'm probably moving to another trust in like 4 months. I was wondering if it's feasible to start something now.
Yeah, it's very, very feasible. So you can do something, like I said, in 2 weeks if it's simple and straightforward. For example, the laxative thing. So that's something you can do in maybe 2 weeks. Do the intervention and do it again in 2 weeks and done in a month. And it's a full cycle audit. I think it's doable and a lot of things can be done. I know some people who actually did an audit in 3 days about handover, and at the end of their night shift, they just did like in the handover, they gave a bit of an awareness about how to do it properly. And we measured it the following week when they were on nights. Done. They had a full audit. And don't forget, guys, that you can always register your audit with the audit department. So they can give you advice or guidance on how to do it. And they give you a certificate in the end that you've done it. So you can have formal evidence. All you need to do is just send an email with your audit idea, and they will give you a form to fill and done. You can always find the consultant supervisor as well, so long as you're the lead. I think you get more points if you're the lead of the audit. So always try to be the lead for that. And like I said, it's very simple, so you don't need someone to tell you what to do. I think someone put in the chat an idea. Yeah, so sorry, QIP and QIA. I'm not sure what a QIA is. Quality improvements. Does anybody know what's the difference between a QIP and a QIA? I'm not sure, to be honest, Favor, but like I said, the quality improvement is a process to improve without a standard. And comparing it to an audit, it's when you have a standard to measure against, for example, guidance or so on. Okay, should I give you guys an idea and you can tell me whether it's a good idea or not? So I'm doing plastic surgery. It's all about plastic surgery for me. But there's something called UCL, or ulnar collateral ligament of the thumb, which is right here. And this ligament is usually injured when it's hit by a ball, for example, or a fall or something like that, and the ligament is sprained. And normally you can diagnose it by pushing the thumb backwards like that and seeing how far it can go. If the ligament is cut, then your thumb will go all the way back because there's nothing stopping it because the ligament is cut. So you can diagnose it clinically, but sometimes it needs surgery to repair this ligament. And some people do an ultrasound to get a diagnosis of that, but there's a better way to do it, which is clinically by putting some local anesthetic injections, so you're actually absolutely sure that the ligament is cut or not. So what I was thinking about is whether we can, there's a guidance on that you can actually, with an accuracy of 98%, diagnose UCL injuries clinically without an ultrasound. Currently in our departments, we do a lot of ultrasounds with these to diagnose them. But what I was thinking is that we don't need an ultrasound and it's a waste of resources. What we can do is to do a clinical examination. We can actually be sure that we don't need an ultrasound because we know whether it's cut or not, whether they need surgery or not. Do you think this is a good idea or not really? Yeah, let's think. Yeah.
It's a good idea, but can you make the other doctors participate in it, or you're just doing it alone?
Yeah, of course I can. If I want some people to help with that, then can get someone to help with, let's say, looking at the data and finding the information about the patients and collecting data on that. And if I get more people to help with analysis and so on, or some people to present it and so on, it depends on the scale you want. Whether you want to look at 500 patients and you probably need more team members, or just 10 patients. You can do it on your own. I think for something like that, you would need like 30, 40 patients. Yeah.
And you said 96% of the time you can get it right clinically?
98, yeah. There's a systematic review based on that and the accuracy of clinical examination as compared to ultrasound. So that's a standard. So I looked it up. I looked up on PubMed and I found the standard to measure against. It has to be good quality evidence, of course, as a systematic review or a clinical guideline on one of the old colleges. Yeah. But do you think it's feasible? Yeah.
It's possible and it's feasible. I think it's a good idea. But at the same time, I feel like after the intervention, we always need that safe of mind of, oh, we saw it in the images. It's good, you know, it's cut.
Yeah,
it's like
you're more reassured
when we're so clear, we're so sure about appendicitis, yet we want an ultrasound, even though the ultrasound doesn't show appendicitis. We'd still order it. We'll go for it if he's young or she's young, but she's old. We'll just be like, okay, we need a CT scan, more investigations, everything. But if it's 98 and it's good, then I think it's a good idea actually.
Yeah. So yeah, if you have, so that's again going back to whether we're actually questioning the standard or not. So if you want to do a research project on whether the clinical examination is accurate or not, then you can do a research project on that. But we're assuming, for the purpose of this audit, that the systematic review is correct, that the 98% accuracy is correct, and we're not questioning that. So that's why I was thinking that if we're comparing, we just want to compare the practice of how many people are ordering ultrasounds, which are not necessary, essentially. That's it. So that's what I was thinking.
Wait, sorry, do they order ultrasound on ice?
Yeah, and there's a delay, so there's about 5-6 weeks until we get the ultrasound.
I thought it was like a ultrasound that was ready to go, and you guys do it in like the same setting.
No, it has to be done. No, it has to be done by an MSK radiologist.
If that's the case, Mohamed, go for it. It's a great project. You're gonna save patients a lot of waiting time and a lot of resources as well.
Yeah, it's just an idea now, but I don't think I have time to work on it. But yeah, it's just an example of an idea. I've got another idea if you guys can analyze it for me and think if it's a good idea or not. There's a nice guidance on by pediatrics about patients with less than 1 year old patients who present to A&E with fever, and they should have their new score taken and discussion with the senior within 30 minutes from arrival, for example, in the emergency department. So if you look up the NICE guidelines by the World College of Pediatrics, I think, you will find the this guidance. So is this a good idea to do an audit on? Is it a bad idea?
That if pediatrics were to present 30 minutes with a fever, they have to be seen by a consultant?
Yes, they should be discussed with a consultant after the initial observations are done, within 30 minutes, essentially.
That's a great project as well, because as you know, it can be hectic sometimes and on calls and everything, and there's always a delay.
Yeah.
It'd be
so if you think
interesting to
about
find
it,
out. Yeah.
So how can we measure that?
No, are you sure it's with a consultant or with a senior? Because I know it's with a
senior, essentially. I think it's a senior, like ST 64 plus or something like that.
If a patient calls for sepsis, high heart rates, fever, and tachypnea, they have a chart. They must always talk with a senior. The nurses are quite good with it. Yeah. But the best to measure from my experience there is to measure if the doctors actually countersign against what the nurses have escalated. Because most times we don't actually.
Yeah, exactly. So our practice is deficient in this particular area because we're not doing it, essentially. That's why you need an audit to improve the practice. That's the whole point. Exactly. Thank you, Favor. So how would you measure that? How would you make sure that, how would you statistically or objectively confirm that we're not doing it correctly and we're not actually discussing with the senior in the right time? It's very easy. You look at the notes, right?
But the issue is the notes. Sometimes the timings wouldn't be accurate. But yeah, you would have to look at the notes and the initial time of presentation, similar to the ECG project that you did as well.
Yeah, exactly. So you find when the consultant countersigned or put their name, or the senior, whoever it was, who actually countersigned, and you find the time of that, and you measure it from the time the patient presented, essentially. And see how many people were seen in time and how many were not seen in time, and just measure that. Now, the question is, how would you intervene? How would you improve that? And do you think it's something that can be changed or not?
I think it can be. I mean, the best case scenario is having a different treatment escalation plan for those particular patients where they're high priority, similar to resus. They just put there's a whole different, they just skip the waiting, skip everything, and they, similar to that, in the sense of there's a different escalation plan. And the well, a better scenario is just that consultants are more aware and they prioritize that other than other patients.
Yeah, exactly. So you can flag it up on the whoever's doing the triage, that whenever a child is in 1-year-old presents with signs of sepsis, they should be seen quickly in a different pathway. Yeah, that's one way to do it. So that's a very good intervention. I think this would make things much straightforward, much more straightforward for these people.
So,
Yeah,
so
exactly.
the way it's done, if they escalate to you, you don't need to really officially see the patient, or you may officially see the patient, but the nurses have to escalate within 30 minutes. Then you see the patient, and if you think it's sepsis, then you have to escalate to Pit Reg or the consultant or whichever one is there.
Okay.
But if you don't think it's sepsis, which on like from my own practice, 80% of cases or even 90 are not sepsis, you countersign and say this is not sepsis. So
Okay.
yeah,
Good.
that's the way it's done.
But
Good.
that's actually
Yeah.
interesting that you brought that up, because if they are suspecting sepsis and they're hitting all the patient criterias, then why escalate to a junior? Why not escalate to a reg or a consultant immediately and skip
Not a
the
junior.
waiting?
They don't escalate to a junior, they escalate to a reg.
Yeah.
Yeah,
A&E,
exactly.
reg, right?
Yeah.
Yeah, exactly. So it's just a use of resources, because you can't have everyone who presented with abdominal pain being seen by a general surgeon, for example. So you have to filter out patients who don't need to be seen first, and then escalate to the consultant pediatrician, who's probably doing other stuff as well, for the cases that actually need to be seen. So that's good. So this is a very good point, because when you're analyzing your patients, you can't just look at the patients who have actually been confirmed by A&E to be suspicious of sepsis and take this as your time for escalation to the pediatrics team. Maybe they're taking 2 hours to find the pediatrics team to see them, or maybe they're taking 10 minutes to get the pediatrics team. So this can be a secondary part or further analysis of results, or something else to look at when you're doing your data collection. So that's a very good point, and that's how you think about an audit. So think about all the factors and how to make your audit actually relevant to answering the question you want about the practice. So that's a very good point. So exactly. So this is what I mean. If you have ideas, you can find a lot of ideas and just think about the steps we talked about, and you can do a whole project. And like I said, you can present it, you can publish it sometimes as well. And it's a very straightforward thing. Any other ideas you guys have which we can work through, or you're happy with that?
I have just one QI project that I'd like to run by you.
Yeah.
It's not an audit. Perhaps I just want your opinion and anyone else would like to share. It's about referrals. So previously, when I worked on Ward 4, the juniors send a lot of email referrals, and then the next day new juniors come and they have to follow up, and it's a hassle because they need to contact the previous junior. So if they had one standard Ward 4 email, for example, where all the referrals are being sent and received through that one email, that would be considered a QI project, right? Not an audit.
Yes, exactly. And you're essentially putting a change directly, but you can always measure. Maybe do a survey to your colleagues who have been doing this process now the way it is, and see how many of them are satisfied with this, how many are complaining, how many are finding it difficult to get the work done, and so on. So you can quantify the issue and do your intervention, for example, having the common email or the standard pathway that you want. And then measure again after 2 weeks, for example, after you've started your project, and do another survey and see how people are responding, how they're feeling now. Maybe you'll find that they're finding it much easier to work, finding it much better, and so on. And you're done. You've done a QIP now. Exactly.
Okay, thank you.
Right. And this is a QIP because you don't have a standard. There's no standard pathway for referrals. But yeah, exactly. That's how you do it. I think that's an idea, but you can always think of different ideas as well. Make sense? Okay. I think we'll end it here just because we're close to time. But if you guys have any ideas or any questions, anything you want to run through or anything that you want to ask, just reach out. You have my number on WhatsApp and just reach out anytime you want. So go ahead and start your own audit now. It's very easy, like we said. Any questions?
Thank you so much for this. It's really helpful. We don't
You're
need a
welcome.
supervisor for any audits, huh?
You don't have to, but you can always get a consultant and give advice if you want, or if you're unsure about something, or if you want a second opinion. And usually consultants are happy to do that, and they get their name in the end, and your name will be the lead because they normally don't care about the audits anyway. So you can always get someone to supervise if you want, but it's not essential. You don't have to.
Thank you.
All right.
Thank you.
Great. Thank you everyone for coming. And I'll keep this recorded, so I'll put it on the group as well. Thank you. Have a good day.
Thank you.
All right.